usually say that medical and behavior really go hand in hand, are just as important as one another. It's just a completely different can of worms, and I think we'd stretch ourselves a bit too thin in the short amount of time today. So without further ado, we'll get started and say, well, how to make adoption decisions for medical cases. And unfortunately, it's a question without an easy answer. I would love for everyone to go home today, go back to their shelter and say, perfect, I heard this talk, Alex told us this is what needs to be adoptable, this is what doesn't need to be adoptable or shouldn't be adoptable in a shelter. And unfortunately, it doesn't work that way. I'll be honest, I'll say that's the first time that I'm giving a formal presentation on the subject, but it's definitely something that comes up often during consultations. And as much as we would want to, or that we might try, it's important to realize that there is no one size fits all when it comes to this question. Each organization has its own medical capacity, and hopefully, though, by the end of today, I'll be able to give you some tools or at least some thoughts for some self-assessments that you can do within your own organization. One thing to note is while comparison is important to other organizations or other shelters, whether locally or internationally, well, this comparison can be important to self-evaluate our practices, to know where we stand within the sheltering community. It could be dangerous to try and blindly compare ourselves to others without appropriate context. And this is like regardless of where we might position ourselves on a specific issue. So we can start with an easy example, which would be canine parvovirus. So this picture is shelter in which I wrote one of my case reports that I needed for my residency, where they had a parvovirus outbreak in the shelter. By the time I was there, these dogs were not clinically ill, but you can imagine by the setup, by how they kind of look, that eventually, yes, these dogs did fall ill in this shelter. So what's important to know with, well, canine parvovirus is that many shelters treat CPV successfully, right? Our prognosis with outpatient protocols, which are very much adapted to shelters, are generally pretty good, varying between 75 and 85% survival rate. Sorry, I did not want to break anyone's ears through the microphone. What's important to note, though, while that is true, another truth is that just treating canine parvovirus in-house does not necessarily mean that we're maximizing our medical capacity either. So comparing yourself and saying, well, yes, I'm treating them and others aren't treating them, it means I'm doing great, which, yes, it is commendable to treat parvovirus. There could still be other areas, other things that we're lacking. So this isn't the barometer of saying, well, I'm treating this and therefore I'm maximizing my potential, because there might be other cases where we're maybe falling short of what we could actually be doing in the shelter. And the third truth is, well, many shelters do not currently have the capacity to treat canine parvovirus in-house, and trying to do so might have actually pretty severe repercussions. I do believe it's something we should all strive to do, but it's important to realize what our current limits is, what our current capacity is, and if that falls within it or not, and what the other options would be in a case like that. So if we come back to our question, right, how do we make these decisions and how do we determine what our medical capacity is? I think we need to look at, well, what determines our medical capacity and what influences it? And one of the first thing, obviously, is, well, the medical staff. And one of the hugest difference we can have is between a shelter and organization that has what we call in-house medical, where they hire directly veterinarians that work full-time or part-time on sites daily in the shelter, or other shelters or organizations that might contract help either through locum veterinarians or they use local clinics. And the difference between medical capacities between those situations can be absolutely huge and very dependent. It doesn't mean that because you have in-house that you have more capacity than a shelter that uses local clinics. But chances are it might be, unless you have like excellent service, excellent availability, which is becoming harder and harder for shelters to find these days with local veterinarian. And then we have the staff itself, right? We're talking about the number of veterinarians, the number of RVTs, the number of assistants too, and even volunteers can all influence this greatly. And above and beyond just the number of people, we're also talking about experience, which plays a very important factor here. It could be, when we're talking about experience, we could talk about just experience as being a veterinarian. For example, I am much more efficient now than when I came out of school and I had to read up on every single drug, every single length of treatment because I did not know them on the tip of my fingers. That could have someone's productivity pretty easily, but it could also mean experience in a shelter setting. How someone is able to navigate within population medicine, create adapted or incremental treatment plans for individual animals at the same time too. So there's that to take into consideration to know, well, if I'm onboarding new staff, my capacity, even though it's +1, it might not be at its full potential for another 4, 5, 6 months, depending on the individual, depending on the baggage that they're bringing into the shelter. And so that's something we have to assess ourselves when we're looking at our medical capacity. And while experience or capability or number of medical staff people can be a limiting factor, it doesn't mean that just because I can do something that I always have the capacity to do it. Unfortunately, ideally it would be the case, but sometimes I have to take into account resources. So obviously money is the big one here, right? If something costs $10,000 for an individual animals, I have to weigh that back on my whole population. But it could also be specialized equipments. Do I have the right tools to do the job I need to do? Thankfully, shelter folks tend to be very resourceful and are able to jerry-rig or MacGyver a lot of solutions to some problems and have come up with a lot of ways of not having the exact equipment we need, but finding actually solutions that work just as well and sometimes cost a lot less. Resources could also be, in the case of an infectious disease outbreak, can be isolation housing that I have in the shelter. Do I have enough room to keep these animals and separated from the rest of my population, or is this something that's limiting? So it ties into what our overall shelter's capacity for care is, and we have to consider that too. So I might have more time to work up a medical case in the winter, where my population tends to be naturally lower than in the middle of kitten season, and we'll talk about that later on as well. Another factor to keep in mind is, well, what are the resources available in our community? Is this something that our GP friends and colleagues can manage if I send this out, if I adopt out this kind of case? Do they have the bandwidth to do it in reasonable time? So am I expecting someone to get an appointment with a veterinarian within the next week when I know that they're booking out 3 months, 4 months at this current time? And is there reasonable access to care? So I know I said I wouldn't talk about behavior, but this is something that comes up often in behavior cases is, yes, maybe as a shelter worker, or as shelter vets, I have a lot more experience in behavior and I might be able to manage this case fairly easily when it comes to the meds and the plans. But it might be something that my local veterinary community, if I don't have access to a board specialized behaviorist, is not comfortable taking on. If I realize that, that's a problem that we should address and try to see how can I how can I help out my local practitioners? How can we help them get better? CE, can I invite someone through the shelter, kind of a lunch and learn that we can do it so that we have access to this resource in the future? But currently, is it a limiting factor, and how does that affect me? We can also think about some community expectations. So sometimes we'll see communities that have expectations that all the animals upon adoption will be 100% perfect, right? Or that they'll all be tested for retroviruses. Or sometimes we'll see that our adoption capacity for certain medical cases might be somewhat limited. All of those are things that we need to take into consideration. And we also need to assess, are these things that expectations that I set up myself as an organization, unrealistic expectations that I'm now having to live up to? Did I give my community a chance to prove to me that they're willing to adopt maybe imperfect animal or animals with some slight, I won't say flaws because they're not necessarily flaws, but some slight concerns or medical concerns that need to be treated over time? And is it just that I don't have clear channels of communication to discuss either with the public or with local practitioners too? When it comes to retrovirus testing, why are we no longer doing it? Why are we still doing it? I'm sorry, once again. Terrible day to lose your voice. So what is the common thread? This is definitely not an exhaustive list, but a pretty good place to start. And what would be the common thread between all of these factors? is that they're all highly variable between organizations and definitely within the same organization over time. So for example, everything could stay stable within a medical department. So my staffing is the same, I have the same budgets, no equipment breakdowns, but external factors can come and affect what I can do. So if I have a large scale hoarding case in the shelter that demands a lot of my time, or an infectious disease outbreak, it might change my population dynamics in the shelter, affect my capacity for care, and really limit what I can do. And ideally, this is reflected on my intake processes to kind of slow intake or get animals out of the shelter faster, but it might limit what I can do medically because there's only so many hours in a day. So as such, we really need to reevaluate our medical capacity on a constant basis, where we want to see both A, are we doing enough? And B, are we stretched too thin at this time? Because we can be in either direction at the same time. Oh, not at the same time generally, but we can be in either direction, and that can vary really over time. So a good place to usually start is to have written policies with some guidelines or baselines, which I think are pretty essential in shelters. They help orient new staff and can help with decision-making processes. They can take many types of forms, so they could be SOPs, they could be decision-making matrices or matrices, I believe. I've seen point systems where medical team determines, okay, we can do 25 points a day and we assign specific amount of points to specific amount of conditions. And that helps me calculate what my medical capacity is. And that works as well too. Some shelters will also incorporate their Asilomar status in there, where the animals fall within a certain category, and this category kind of tells me what I should be doing with this animal at most time. However, as essential as written protocols can be, they can become quite useless or even a hindrance if they aren't reassessed and updated to reflect the current situation at the shelter. I cannot tell you the number of times I've asked the shelter for protocols, and they hand me something that was written by the person who trained, the person who trained, the person who trained, the person I'm currently talking to and who's working at the shelter. And while I am a staunch believer in the if it ain't broke, don't fix it, we have to remember that our organization and capacities are dynamic and change greatly over time, and our missions might also change over time. And can create a lot of frustration. If I, as a veterinarian, believe we have the capacity to treat something, but a piece of paper is telling me I can't, that becomes very hard to live with on a daily basis. And so it's something that can't be stagnant. It can't. It has to be reassessed and revisited often. Usually, at a minimum, I'd like it at least twice a year. And so despite this, even if we do reassess it twice a year, we still might not be able to capture everything we want, which is why we need some flexibility in there to adapt to our current situation, which is odd to say when I'm talking about written policies, because in a sense, when we have things written down, it's often to avoid having this flexibility or uncertainty in things and make things as binary or clear cut as possible. However, as we explained with the fluctuating capacity, we want to be sure to be able to adapt to different periods, even between reassessment of our policies. So we want to avoid applying what we might call like the lowest common denominator when we're at our maximum capacity to the rest of the year, for example. And I think historically, I've had a pretty firm, staunch approach where I'm not a big fan of matrices, where if an animal falls in here, this is the automatic outcome that's happening. And I think many of the times my true issue is not necessarily with the matrix itself, but how it's applied to a shelter. To know that, yes, this animal might fall within the matrix as a euthanasia candidate, but right now we're assessing our current situation and we're saying that we have the bandwidth to take and the capacity to take care of this animal and to give it a good adoption and to give it an adoption chance. And therefore we move forward with that instead of just saying, well, the piece of paper is telling me I need to do this, and therefore no discussion, nothing is happening. This is what we're doing moving forward. So how do we take that step back and evaluate ourselves? And so we'll need to answer a few questions when faced with a medical case. And most of us will do this on a daily basis, one way or another. But I think it's a really good idea and exercise to break down the process. It's also a very good way to present the information to different stakeholders and decision makers in the shelter to help you along the process. And especially useful if you're working as a locum or if you're not working full time in a shelter and you might not have all the information you need, or you might not even have, even as a veterinarian, decision-making power in the shelter. So if you're at a clinic who works with a shelter, they're the client, they're the owners of the animal and they'll be making the decision. And so these are questions that'll help them make an informed decision and maybe lead them down the path of reevaluating what their capacity is. And it definitely might require some input from different departments as well. So this is something that can be discussed at rounds, which is a really good process if we can keep it nice and efficient there. We won't have time to talk about rounds today. I could talk forever about rounds, but definitely something that we can incorporate in there. And so 4 questions that I have for today that are definitely not exhaustive, and every situation has its own quirks that would probably need to be addressed. But the 4 kind of major ones I usually have is, can I treat this condition? What is the expected length of stay and the needs of the animal? Is this infectious? And what is the adoptability and prognosis of this animal moving forward? So first off, is this a case we can realistically manage in a shelter setting while providing a level of care that we are comfortable with? We'll stay away from using gold standards, and I urge you to do the same for multiple reasons. A lot of times the term is used to kind of put down incremental care or other treatment plans that sure are not the quote unquote gold standards, but work very well and might be even more indicated in a specific time as well. So in this case, we'll just talk about level of care that we are comfortable with, and we're veterinary professionals. I think we all have that judgment to make those decisions at the same time. First question I like to ask myself, well, can I provide pain relief or pain management? And if the answer is no, I don't move forward from here. If I don't think that I can provide adequate pain management or relief for this patient, I don't want to be adopting out suffering animals, and I don't want animals to suffer in my care. So always the first thing, in my opinion, to look at is, can this animal be comfortable? Am I meeting its freedoms? Is there a comorbidity that's involved here? So sure, I could treat a patient with parvo, but if this patient has severe hydrocephalia at the same time and is clinical, this might not be a case that I want to invest resources on, because that comorbidity comes and affects everything at the same time, but both factors alone might have been an adoption candidate. Do I have expected return to function? So do I think this animal will get back to normal? If I don't think it'll be back to normal, do I think it'll have a good quality of life? Do I think it's something that will affect this animal long term? And if so, up to what point? And so what's my prognosis, right? The immediate, but also the long-term prognosis, which we'll talk about in a bit. And is there a better procedure, treatment that is easily accessible? Can I do it in shelter, or is it something I'd have to refer to be done? And so for an example that we can use for this is, we can use the example of a limb fractured animal where I could either amputate or try and salvage the limb. And either, in some cases, some people might be able to do that in the shelter, or it could be something done externally. Now, I think we would all hope that we could always save every limb on every animal at the end of the day. That would be wonderful, but it unfortunately might not be the case. And we'll talk a bit on this next slide here. So the second question, expected length of stay and needs. So first of all, I want to think about, well, what is the overall length of stay to recovery, and when I can make this animal available for adoption? So I might not be able to kind of say exactly how long I think the length of stay, but I could say, well, this animal will need a month before being available, or will need a week. So for the example where we have the amputation versus maybe the orthopedic repair in the animal, well, in the case where we're doing the amputation, that animal was probably available for adoption within the week, versus the orthopedic repair, we might be looking at weeks to months of care in shelter. And there's no right or wrong answer. I think we have to self-assess and say, is this something I can do? Do I have the capacity to do this? Is this length of stay to time of adoption going to have to be in shelter, or is it going to be in a foster home? How many foster homes do I need? How many do I have available at the same time? And how often will they have to come in? And is this a realistic expectations that I might have from a foster home? What are the daily resources needed from this animal? And this is a really important one in my opinion, and one that we might not be asking ourselves often enough. So what is the specialized staff time that I'm expecting that this animal will need, and what is the availability? So let's take once again that example of amputation versus orthopedic repair. If I am doing an amputation, probably morning rechecks and comfort during the day and few rechecks here and there, but probably less than 15 to 20 minutes a day. Versus if I have the orthopedic repair, or if I have, like, for example, a splint on an animal, well, how long does it take me? How often do I need to do bandage changes? How often do I need to take radiographs? And how long does that take me each time? If I'm doing daily bandage changes on an animal, that takes a lot of time because I'll need both my RVTs and my DVMs working on that case, probably for sedation, which is needed in most cases, and that needs to be taken into account. We also need to take into account money, unfortunately, right? It's the reality of what we're doing is, I might have a surgery with a really good prognosis, but at the end of the day, it's going to cost a bit more, and that money, then I cannot spend it on other animals that are in my care. If I go through this whole exercise and money ends up being the limiting factor, then I should take a step back and be like, everything else would work except the financials. I talk to my other departments, is this something I feel that I can fundraise for? Is this something that we think that we can display this case, hopefully positively, right? We want to move away probably from using negative stories and emotions to kind of get money for animals. But is this something that I think I can resource my community to kind of help me crowdfund what I need and maybe get more that I can spend on more animals at the same time? So even though it might be limiting, it's one that we might be able to look at a bit easier from another perspective. And when we look at the daily resources we need, we can do the same thing too when it comes to specialized vet time. Is it something I want to outsource to an external clinic, or something that I want to do in-house? What is my capacity versus the cost that it's going to incur? Third question I ask myself, well, is this an infectious disease? Because if so, I will need isolation space. I need to know how much is needed for this or these animals, how much is available, and how much do I need on a daily basis. So if I usually have about half of my isolation space that is full because I have a lot of infectious disease where I work coming into the shelter, well, I cannot necessarily keep a case that's going to take up my whole isolation ward. I have to find solutions, ideally foster, maybe transfer to another organization, and that might be a limiting factor on my medical capacity. I have to also look at my current population and the transmission risk in the shelter. What is the transmission type of this particular disease? Is it direct, vector-borne, aerosolized, fecal-oral? What's the incubation and shedding periods? Right, all to take into consideration. If this animal has a very, very long incubation period or a very long shedding period, that might limit me in what I might be able to do. I'll look at my facility. Is my facility working for me, right? So in the case where it's hard to always be able to trust staff 100%, knowing that mistakes are human. Is my facility helping me reduce risk? Do I have appropriate and good isolation space where I'm reducing risk just through how my building is built? Or do I have just one large dog room where I don't really have that option of separating animals easily? And sometimes I can do a functional isolation there. What is my staff training level? Is it something they've been trained to do? Is it something I can't train them to do? And is it a good expectation that this is at their level where they can be wearing the appropriate PPE and I trust them not to contaminate themselves or other animals in the shelter? Do I have 60 puppies from a hoarding case in the shelter, and I have another parvo case in the shelter right now? And if that's the case, if I have that one parvo case and the 60 other puppies, maybe that is a higher risk because I have so many puppies in my care and I don't have the right isolation, where I have to maybe find another solution where I would usually treat this animal, but because of my population dynamics, I'm looking at myself, assessing and saying, the risk might be just a bit too high right now because I cannot fast track these puppies out of the building because they're on a legal hold right now and these other factors. Next thing I want to look at as well is, well, what is the risk of this disease spreading in our community? Is this something that I'll be putting out there and creating a somewhat natural disaster? Or is this something that's already present in my community and the risk is fairly low in itself? And we'll look at the parvo example in just a few slides. And then the last point is, well, are we pot committed otherwise? And pot committed is an expression when you're usually gambling and playing poker, where you've put enough money in that at some point it's just not worth it to stop. You might as well see this through at the end. And cases like this will generally be when you have like a highly virulent pathogen that comes in, like canine influenza, and it took you a few days to catch it or diagnose it. And by that time, probably everyone in the shelter is susceptible and exposed to it. Euthanizing the first 2 diagnosed cases is probably not helpful unless you're planning on depopulating your whole shelter, because at the end of the day, most animals are probably going to be exposed and probably going to become sick. And depopulation is rarely the answer at the end of the day. There are many. If you're ever at that point, please contact me. I'd love to help out in any way I can. And so there's that to consider too when we're looking at medical capacity of, is it actually like, do I just have to treat this animal anyways because I'll have to treat my whole population and isolate my whole population, and therefore I should keep this animal instead of making a decision I might regret? And finally, we want to look at adoptability and prognosis at the same time. So we want to know, well, what is our shelter's overall capacity? And more importantly, in this case, what is our adoption-driven capacity? So what's my local pool of adopters? Do I usually have a lot of people coming in to adopt quote unquote broken cats or stuff like this? Or is it something we see maybe once a year? And if that's the case, well, how many animals, how many similar cases do I currently have in my shelter? So if, let's say, I can say, well, I probably have one person that comes to adopt a diabetic cat every 3 months. Well, if I have 3 diabetic cats in the shelter, I know my length of stay is going to be very long, right? Probably around 9 months, because average length of stay, because that is how long it's going to take to have turnover in those cases, because I don't have enough people coming to the shelter. Now, it is good to also look at historically, what has the length of stay maybe for these particular cases been in the shelter. Though I do take that with a grain of salt sometimes, because we might not have had a diabetic case for the past 5 to 10 years, and there are many things that change within that time. But it could be a good idea to still look to see, well, historically, how long have they spent in the shelter? Is this something that aligns with my current capacity at the same time? And sometimes it's good to just push the envelope too, to say, okay, 5 years ago, we tried the diabetic cats, it didn't work. Maybe we have a small pilot program right now to see, has anything changed within our community? Because you won't know if you don't try at the end of the day. And then we want to look to at what are the possible barriers to adoptions in this particular animal. And when we're discussing barriers, we're talking about barriers that the animal sets for itself and not internal barriers to adoptions. This is unfortunately, well, fortunately, but not a whole adoptions talk, but I recommend everyone go read. This is probably one of my favorite reads of all time. It's Adopters Welcome from the HSUet. So assuming we don't have internal barriers to adoptions, what are the barriers this animal is setting for itself? So what is its long or short-term prognosis that it has in the shelter? What is the cost of care that it's going to incur and the frequency of follow-ups? Because the cost might not be that high, but just the fact that people need to take time off to go to the veterinarian maybe every 3 months might be a huge hurdle. And what is the possibility of me giving post-adoption support to these people and to this animal? Because that might change also, that might help me place harder to place animals if I can guarantee that I can help you out, or I can do some of that post-adoption care for you. That might really change what I'm able to put out in the community, because I become the resource. I'm no longer limited by some of the costs that might come from general practitioners, as well as some of the bandwidth problems that they might have at the same time. So, case example, all right, something that I've seen often is shelters wondering, should we be treating canine parvovirus in our shelter? And this is a very cute dog. It was my last parvo case that I treated during my residency. Community dog that we treated at the shelter because they had gone to referral clinic, couldn't afford care anymore, and we took over from there. Absolutely adorable. He unfortunately absolutely hated me because I was his primary caretaker, but I loved him nonetheless. So first question I asked, can I treat this? Absolutely, yes. I have a pretty good prognosis of 75 to 85%. That has been more or less my success rates, usually more in practice. And return to function, this dog will likely come back to normal in most cases. So one thing to note, dogs that recover from parvovirus have been reported to be at higher risk of some long-term GI issues in one paper. So one thing I like to discuss with adopters, but otherwise, I'm not expecting many possible long-term consequences with this dog. What is the expected length of stay and the needs of this dog? Well, I know it's probably going to take 10 to 14 days before I can place them to adoption, and I'll need isolation placed during that time. So length of stay in this particular case will really depend on your tolerance of risk and your current population. Many people will move their dogs faster after recovery with no negative consequences. But we do know that some dogs can still be positive on cell culture until day 13, which kind of places us in a bind. But if you move them faster, I think everything is in risk assessment. Costs, we have a nice paper that came out of Pennsylvania from a low-cost parvo clinic that said it was about $300 to $500 per case for an outpatient protocol to treat. So that's fun. I don't even have to make the internal calculation. Daily staffing needs, I'll probably need about 1 hour of DVM RVT time for 5 to 6 days, which would include reevaluation of this patient and administration of treatments. And definitely I'll need to give it 1 bath before it leaves the isolation area so that it's nice and clean. Is it an infectious disease? Well, absolutely it is. And like we discussed, shedding is usually subsided by 10 to 14 days. It is something that is environmentally hardy, right? We all know it's the poster child for it. But exposure can often be easily controlled in parvovirus. Sometimes I feel like we're a bit too scared of it. So it's not aerosolized with double-siding housing and proper use of disinfectants. So concentrations and contact time and PPE, I can severely limit the risks where even if I don't have true isolation space, so like physical isolation where it's another room, a functional isolation in a room where I could block off just certain walking paths and I could block off this particular kennel and maybe a few kennels next to it, can allow me to have a pretty good functional isolation that is low risk and establish a clean break in my shelter. And these are not lifelong shedders. And so the community risk is pretty low following adoptions. And the adoptability is generally pretty great, right? We're talking about puppies, good prognosis, very little, if any, follow-ups. But once again, the limiting factor in this case might be the 1 hour of DVM to RVT time needed per day for this individual animal, or the staff training needed to not have exposure in the shelter. So I need to look at my organization, my specific area, and say, is this something that I can treat or not? In my case, it was. Now, if I go to another example, which is maybe the other end of the spectrum, which is a diabetic cat coming into a shelter. So this is adorable cat, part of a ringworm outbreak, unfortunately, and as you see him on the on the water fountain there, I felt it represented well a possible PUPD cat because she was just waiting for us to drink water and drink with us. So this cat comes in, it's a diabetic cat. Can I treat this case? Yeah, probably. I could manage it most likely. Return to function, maybe. There's a chance of remission. There's a chance that this animal has no more clinical signs, but maybe the chances of true cure is not that great. It might depend on when the diagnosis was made that this animal come into the shelter, a known diabetic, or if it's an animal that I had to diagnose in the shelter, and how long has this been lasting. Expected length of stay and needs. Now this becomes very valuable. It could be 1 to 6 weeks, depending on if this animal was pre-controlled when it came in, or if I need to do the blood glucose curves and control it. And I'll need daily staff to give Q12 hours insulin injections, which for me was absolutely not possible in a shelter, but it might be possible in a foster to get really those 12-hour apart injections. And I'm looking at medication costs for insulin, probably around $30 to $50 a month based on current prices, but it depends on how much insulin the cat will overall need. Is it an infectious disease? Well, thankfully, no. Infectious diabetes would haunt my dreams, and so I'm happy it's not the case. But then we get to adoptability, where it might be a lot less good, right? It's an older cat with intensive treatments and unfortunately a very steep learning curve for new adopters. Well, we often see that the people who adopt diabetic cats are people who have had diabetic cats in the past and were not traumatized by the experience and kind of want to rekindle with that connection that they had with their previous cat and kind of say, I'm good at this, I can handle this case, and it's absolutely wonderful. And so we might have a pool for that, but we might not. It very much depends on our location, size of our community, and all that. Prognosis, I mean, somewhat poor. It depends on the individual case. Median of 2 years survival, but could be much more. And there needs to be an initial follow-up where they need to go see a veterinarian, and then they'll probably need 3 or 4 to see them every 3 or 4 months. So in this case, the resources, length of stay, and adoptability might all be limiting factors. Not to say that this is an automatic no in every shelter, because for some shelters, these might all be factors that they are completely still within their capacity to do. And if that is the case, then absolutely, you should go ahead and treat and place this animal up for adoption. Or it might be that in your shelter, we can say, well, if an animal comes in, surrendered, no comorbidities, and is previously controlled, so I don't need to do the blood glucose curves, which I didn't discuss, but it's time intensive too. I don't need to change insulin dosages or anything like that. Well, in those cases, I can move forward. But if I need to do the workup or if I cannot control them, it might be a case that we're not moving forward with. And I think that's a very valid approach also at the same time. So that mostly covers kind of my process on who do I make available for adoption. But there remains a burning question of when do I make animals available for adoption? And what's important to note is that holding animals back unnecessarily could be just as damaging as moving them through too fast. So I always look to reduce the length of stay when possible and track animals out of the shelter. Because if you've heard me talk before, you know that I say this all the time, 1 day is not just 1 day. So quick capacity reminder, right? Our daily population is the product of our average intakes with our average length of stays. So a shelter that takes in 3,000 animals per year, reducing my average length of stay by only 1 day means that I have 8 less animals in the shelter at any given time, which is huge. If I had 8 less animals to take care of, it means that I have the time to take care, to spend resources on a lot more animals, well, 8 more animals in my care, and I could focus on the animals that really need me. So quick kind of reminder of capacity for care and calculations there. So once again, when do I make animals available? Well, it's once again the time to ask questions. I like to ask, well, is this an infectious disease? What is the current health status of the animal? And does this animal require ongoing specialized care? And these questions, like this whole process, can be adapted. It could be made into a protocol. It could be made into a flow chart. Like there are so many ways to apply this to our own situation. And if you do develop anything from this, like a flow chart, I'd love to see it too, just to see how individual shelters are managing this at the same time, or how they make that decision-making process. So when do I make an animal available? And this is considering that the animal has a medical issue, because if the animal has no medical issues on intake or in its history, everything seems good, behaviorally sound. Like we don't want to do intake quarantines. We want to make these animals available as soon as possible to reduce the chance of in-shelter transmission of disease or behavioral deterioration. So for this exercise, we're considering that these were animals that we had to hold back, and we want to know when is it good to move them forward into adoptions. So is this an infectious disease? Always a good question to ask. I want to know what's my current population and the risk of transmission in the shelter. If I'm making this animal available for adoption, I'm likely increasing the risk of transmission of disease just from foot traffic, from interactions with this animal. So I want to know, what is the shedding period? Is it still ongoing? And is it possible for me sometimes to test to be able to clear this animal faster? So this is especially useful if we're talking about disease with long periods of shedding, for example, distemper, which can shed for up to, I've had cases up to a year that have shed, and there's a recent paper that came out with even longer on PCR. And so I will not isolate, I don't want to isolate a dog for a year if I don't have to. So instead of looking at that, I might just try and test this animal to see, well, can you show me that you're not currently shedding, and can I put you back on the adoption floor with minimal risk? If not, we can always use empirical data for short periods that could be useful too. So things like parvo, which are, for me, not that long shedding periods, empirical data might be more useful to use than to put the money into PCR testing. And there's some awesome new empirical data that we can use from feline parvovirus at the Toronto Humane Society that we can use for decision making. I want to know, once again, well, what is the risk of disease spreading in my community if I make this animal available for adoption? Normal or novel pathogen? And what is the exposure risk and possible control methods that could be put into place? So when I'm talking about risk of spread, I want to look at, well, is this vector-borne, and do I have the appropriate vector to transmit this disease geographically and at this time of year? Is it a cat versus a dog, where this cat is probably going to be an indoor cat, and the risk of transmitting to our community cats is very low, especially with proper counseling at the time of adoption. It could be too, for example, we have something like heartworm, which in theory is infectious, but at the same time, with appropriate treatments at the time of adoption and ongoing treatments, that risk of transmission becomes pretty darn low overall. And this might be a case that I adopt out before completion of treatments with proper counseling, and ideally, if I can do the follow-up treatments that are needed, adapted to a shelter setting. I want to know, is this a zoonosis as well? One of the, for example, ringworm, most people are hesitant to adopt out ringworm positive cats before cure because it's a zoonosis, and that is completely understandable at the same time too. So all these factors to take into consideration. I want to know, well, what is the current health status of the animal too, right? How does the patient look is a weird question to ask, but kind of important. This is a little dog I came across during my residency who had Demodex all over and needed treatment for it, which is pretty simple treatment, but they decided to hold on to this dog for it to kind of look a bit better at the time of adoption and make sure that it was trending in the right direction, even though there was nothing really more that the shelter was providing it other than time. Sorry. So this takes into account what the image we're putting out, the type of dogs and cats that we have available in the shelter at the same time. And this might be a decision that we don't make as veterinarians ourselves alone, but we take into consideration other departments, we get their ideas, we get their input on it so that we can make an informed decision as an organization. We need to know, are we out of the woods yet? What's the prognosis and what's the risk of this animal to deteriorate? So obviously, I don't want to adopt out an animal that I think, well, he still has a 50-50 chance, but I don't know. Maybe I want to gather a bit more information at this time. Is this animal stable or controlled? If you've treated IMHAs in your shelter and you want to put those cases available for adoption, maybe the right time isn't right a week or two after the transfusion when he's still on his full dose of immunosuppressive therapy. Maybe you want to wait till we've tapered off a bit more before we place this animal because he's not yet stable, not yet controlled, and my prognosis, it's probably good at this point because we made it through the acute part, but there's too many uncertainties and we might not be able to inform the adopters adequately and have good transparency and set them up for success with the information that we have at this time. And then, is this something that could be followed up easily with a local vet, or am I dropping a bomb on them? Going back to this IMHA example, where more and more shelters are treating these immune disorders and doing transfusions, I would not like to just be thrust in the middle of an uncontrolled case that comes up and I have to now read up on the whole file and do the whole tapering. it might be something that they're comfortable with. It might be, if that's the case, I might want to call them before and be like, hey, once this animal is adopted, can I refer them to your clinic? Are you comfortable doing this? If that's something you're allowed to do, obviously. But discussions to have with local veterinarians to see, are they comfortable or not? One of the things, distemper is a perfect example, where local veterinarians are often not very aware of how to follow up on a distemper case, and it might be a lot easier to do it through the shelter, and a foster to adopt program might be more interesting there, or just doing the follow-up care with them or the follow-up PCRs as needed. And then the final question is, does this animal need specialized care, right? Is there any reason I'm keeping him in the shelter because he's getting something from me that he would not get from an adopter? So this could be treatments, right? If I'm on injectables, usually not something I just want to thrust upon an adopter for acute treatment of injectables, so fluids and stuff like that. I probably want to wait and do that in-house. And then if it's something like insulin, then I want to teach them if needed at the time of adoptions. But oftentimes we're talking about treatments here that cannot be done, cannot be expected from an adopter. And sometimes it's things that we would trust our foster parents to do, but maybe not an adopter, because that learning curve is too steep and we might not be able to provide after adoption care, and that might limit us in what we can help them with at the same time. But it could also be monitoring and necessary adjustments. So if we're once again back to not out of the woods yet, I want to have a veterinarian recheck this case every few days. In that case, it might not be a case that we want to put on the adoption floor just yet. And then the if yes, what frequency is needed and what can I offer to do at the shelter? So if it's something like physiotherapy that I feel comfortable that I can train an adopter to do, and I can do the radiograph rechecks in a few months and all that, something to consider. But we have to make sure that it's something that we can do and we can realistically offer and kind of budget the time for that. So case example, of CRDC, something we see fairly frequently in shelters. So is this infection? Well, yes, it's likely. Oftentimes we might not test for uncomplicated cases that aren't outbreaks, but yes, it's likely infectious. And the risk of spread in this case can be somewhat low in the community with good counseling, right? Of how long to keep this animal away from others, and using empirical data for shedding to help reduce risks if no pathogen or is identified, or if no severe pathogen is suspected. So if I have an outbreak of unknown origin and dogs are getting very sick, or if I suspect influenza, then absolutely I want to keep this animal away and isolate it, and be sure that it's isolated and not be a source of community-acquired disease. But if it's just your run-of-the-mill CRDC, then at that point, it's probably okay for this question to let it go out of the building. From the current health status, I want to see, well, is this dog doing well? Is it eating well? Does it have pneumonia or not? How does it look energy-wise? Is this something that will just be stressing adopters out because this dog looks dumpy, and maybe a few days to kind of get that energy level back to normal would be a lot more helpful. Can I inform the adopters about what to look for in cases of deterioration? And usually, well, sorry, in this case, I can inform them, and it's pretty easy. And in this case, the follow-up is pretty easy and oftentimes not required. So that is not a huge barrier in itself. Does this dog need specialized care? No, it's on oral meds only, pretty simple monitoring and clear instructions. And if anything, it might benefit from being in a home where it gets more access to fresh air than being in the shelter for prompt recovery. So uncomplicated cases of CRDC, I usually leave them available for adoption in most cases, with some good counseling at the time of adoption to help reduce risk in the community. Now, if we go to another case, and this was actually, that previous dog was part of the same outbreak of this dog, which if it's an outbreak, things change a bit. But in this case, if we looked at this dog, she was clearly not doing well, right? She was coughing and retching. She had pneumonia, actually. And that energy level is concerning, right? So I will not place this dog available for adoption because this is not a good adoption candidate at this time. There's too many unknowns on prognosis. It needs specialized care and monitoring. And the dog health status currently doesn't look good. And I think this is a lot to put on to an adopter at this time. So how we can have both of those, kind of that same situation where they're both similar disease processes, but at the same time, the outcome of placing them to adoption is different because of individual care. Sorry. So key takeaway points for today. I know I'm nearing the end and I want to leave some time for questions. So comparisons can be useful, but they always need context. Ask yourself questions to self-assess and do it often. And sometimes you won't know if you don't try, and it's worth it to try and to say like, hey, we tried it, it wasn't great, or hey, we tried it, it worked out great. We can now maybe try to expand this into having more of these types of animals available for adoptions. And remembering that getting animals out efficiently can have huge impacts on a population level on top of individual level medicine. So leaving it open for questions, I hesitated longly before putting this unflattering picture of me, but my phone popped up this picture this morning of this cat, which is was the love of my life, and she was just so adorable on it that I could not share her with the world today. But any questions, I'm open to anything. If you have questions on how to evaluate or how to navigate this in your shelter that you don't want to address today, you can always email me at any time. My email is up there, and I think it was shared in the chat during today's presentation. All right, so I'll read the questions out loud because I realize that this is recorded and people might not have access to the chat afterwards. I wondered if you share your thoughts on whether inability to obtain a definitive diagnosis at all for an animal would limit your recommendation to make that pet available for adoption. This is providing that the criteria around pain control management, overall quality of life could be met adequately without significant lifestyle changes or expense to a potential adopter, but perhaps resources are not in place to perform exhaustive workup in the shelter. Absolutely great question. And I think in most cases, I would say I do not have definitive diagnosis in most cases in shelters because we're talking about sometimes diarrhea, behavioral concerns where I cannot do like a full behavioral exam and all that. But I go with what can I do to make this animal comfortable? Is it responding to treatment? Yes or no? And I think all of your insight of saying that pain management, quality of life are all met adequately, and lifestyle changes or expenses to potential adopters are limited. And I think the caveat in a case like this will be that we have to be very open and transparent with adopters so that they know what they're getting into. So I can say, this animal has XYZ right now. I'm not too sure what's causing it. From our list of differentials, doesn't seem like the most likely right now, doesn't seem to be something that's potentially, we do recommend follow up with your vet. These are things that you might be able to do. And that goes a long way into setting people up for success and having success in our program and our adoption programs at the same time as well. I hope that answers your question. It's difficult without having a specific case exactly presented to you, but I think you did most of the legwork yourself on that one, which is great.
Thank you so much for an incredibly thoughtful and informative talk about a subject that I think we all struggle with all of the time. So that was really, really well framed. Thank you.